Hello, and welcome to Level 5 Health and Social Care. And we're starting a new unit, 502. And Unit 502 is basically about the management of quality. Okay, so it will be building on some of the work you've probably done in Level 4 and Level 3. Okay, so there are some things I probably won't go over because I know you've done them, but I might just refresh your mind about them. So, week one, we're looking at really what is the role of quality assurance, and then we're going to look at some models of quality improvement. Okay, let's look at the criteria that we are going to be working to this week. Okay, we're going to be addressing task one and the two criteria from task one. 1.1, which is critically discuss the role of quality assurance in health and social care. Right, so what do we do in quality assurance, but focused on health and social care? So don't bring me in stuff about general quality assurance in business, in education, anything like that. We want to try to focus it on health and social care. So if you do any examples, make sure they're health examples, okay? 1.2, we're going to critically discuss two different models for ensuring quality improvements. And I'm going to talk you through the two sort of very commonly used models in healthcare and the NHS in particular. But I will remind you, you can read wider than that and look at some other models, but you need to have evidence that they've been used in health and social care again. So don't forget, business uses all sorts of quality models, but I'd like you to sort of focus on ones that are commonly used in healthcare. And I'm going to go through the most commonly used ones. Okay, let's start with the definition of quality assurance. It's a noun. And the Oxford Dictionary sort of basically says it's the maintenance of a desired level of quality in a service or a product, especially by means of attention to every stage of the process of delivery or production. Okay, so it's really about setting a level that you want to achieve. Another definition is quality assurance is any systemic process which determines whether a product or service meets specified requirements. So here, when we're looking at healthcare, we're talking about probably meeting set standards that we know that all aspects of healthcare have. Okay. So let's sort of think about it in care. We know that by definition, there's no one size fits all in personalised care. We've talked a lot about person centred care, personalisation. The right balance for one person is different than for another person. And that will also change over time as people's circumstances differ. So we can't always make assumptions that the person will be happy with our services because they were happy last January, that they're still happy with them this January, because things might have changed to them, their needs might have changed, and we might not be meeting them. So just be aware of that, when you do your work and when you think about it. And that's why we have to check in with them on a regular basis to make sure that we are still meeting the quality that the person wanted of us. So really, for our health and social care services, the consumer is the person who will decide what a quality service means to them, um, and how that should be delivered. So we know that we need their input whenever we're setting our own standards. Generally, those because of this, a care and support service can only be considered high quality if it places that person receiving it at the centre of the care, as in person centred care, we know that, and it enables their personal outcomes to be achieved. So not the doctor's outcomes, not the nurse's outcomes, not your outcomes as a care worker, but what that person wants. And relationship between the person who's using the service and the people who deliver it should be based on dignity and respect. And if you do address all those three areas, there is a good chance you're moving towards a high quality care service. Well, why do we need it? Because we need to evaluate what we do as a service. We need to find out where our strengths and weaknesses are so that we can address them and make changes. We need to learn as a service so that we can improve what we offer and deliver what the resident needs. And then remember, as I said, what the resident needed last year might not be what they want this year. So by checking our quality regularly, or at least on a sort of fixed basis, we can make those changes. I've said here that another thing that identifies high quality care, the sort of things that you might see in lots of documents about quality care, are these sort of four areas there. The person is enabled to live independently as defined by themselves, and that they have as much involvement in decisions around their care as they want to have. That the person has opportunities to participate in community life, both maybe within their care home and in the wider community as well, and to carry out activities that meet their interests. They also need to feel safe and secure and empowered, and their human rights need to be safeguarded. And also, risks are managed in a way that they are happy with. And they should have a positive experience of care provided through relationships based on a mutual respect and where the care is designed around their needs. And again, these sort of standards are the sort of things you'll see reflected in CQC documents. And generally, if you're addressing all four of those well, you're probably working, or providing a fairly good quality care. If the service user agrees with your evaluation of your care. Okay, so those are your drivers, really. Those are the things to always keep your eye on. And if you think you're veering away from one of those, you maybe want to talk about it as a team, raise it, really. But what we do need to do, as well as this day to day, keep your eye on those sort of four areas. You need to also do a proper evaluation with the service users, maybe with their families, maybe with other people involved in their care. Like I said, a lot of teams might do at least an annual review of how they're getting on, things like that. And you need to find out if there are any processes that need to change. And there might be lots of reasons why they need to change. It might be the service users' needs have changed, and therefore you need to change your process. It might be that there's new legislation that's means you have to tweak your processes to meet them. So that's why some sort of at least annual review of the quality of your performance should happen. So what sort of measures, the sort of questions that we can ask ourselves when looking at quality is, what are we getting right? And conversely, what are we doing wrong? What's not working? What's failing? What could we do better? Are we doing things the best way with the resources that we've got? Can we be more creative with them? Can we be more imaginative? How well are we working with individuals, families, and carers? What's their satisfaction like? Are we delivering our commitment to provide independence, ensure safety, and support recovery? Are there areas where we're failing? Are we not, you're not making sure they're getting enough independence? Are we not making sure that they're getting to do those activities they've always loved to do? Are we not making sure that they're getting that involved with the community outside as well as just inside? Are we safeguarding vulnerable adults? Now, we know there's legislation around safeguarding, so we do need to meet that as well. So we would need to review our performance against that. Have we got any safeguarding incidents? Have we learned from them? Have we changed any processes because of it? Are we fulfilling our duties? And that's duties as per our contract or per our code of conduct and working within regulations. This might be a team reflection. This might be where we've, have a look and check up those things and think and have a look at our personal one-to-one supervision and our own personal reflections as well. Are we meeting up and upholding standards of best practice? There's plenty of standards available for health and social care. Some say there's too many. But there's a lot of standards for you to value yourself against, really, for you can do in your evaluations. And are we supporting our staff to carry out their jobs safely and effectively? And this is a sort of an organisational review or a management review, really. Are you looking down, are you providing safe spaces? Are you providing the right amount of PPE? Are you maintaining hoists and other machinery to make sure staff can do things safely? Have you got enough staff on shift to make sure that the work is safe? So there's lots of things you could be reviewing there. These are the sorts of measures you would consider when you're putting together a quality review. We've mentioned standards. They are developed to support the improvement of practice, and they give you very clear guidance. As I said, those of you working in a care home, you would have some organisation, and some of you are international, I know, but there will be some organisation in your own country that tells you what standards you should achieve for that care home or that hospital service or that clinic service. So you would work towards them. They may be organisational, they may be national legislation. In the UK, we use CQC. As you know, they register all care homes. And we also have a code of conduct for the workers as well. The nurses have a specific code of conduct. Social workers have their own specific code of conduct. Doctors have their own, and so do care workers as well. And we've discussed that during our level 3s and 4s too. So we know our codes of conduct and we know what standards we're expected to work to. There is also corporate governance, and again, that's usually within the organisation, and it will be the fact that you will have written processes and policies within your care home or your clinic that you have to follow, and that's part of the corporate governance process to ensure that the organisation works well. It gives staff a framework in which to operate, and it allows people to sort of trust each other. If everybody knows that they're meeting the same policy, then you're all working in the same way. And that also looks at some of the accountability, who's responsible for what. That should be somewhere in your processes and your policies, so you know how you should behave. And it will have things like safeguarding stuff. It will have things like data protection. It would have things like, general performance standards. It would have how to, health and safety issues. It would have management of fire, how to evacuate the place. So from very basic things like that to more complex things like writing up reports, filling in the daily logs. There will be processes for that. You know that because most of you are working in the field. And you know that if you work within the processes, you'll be supported by your organisation. If you work outside them, not so much really, and there will be disciplinary issues. So we keep hearing quality assurance and quality improvement bandied around. Some people think they're interchangeable. Well, they're not actually. They are different things. And for the rest of this assignment, we're pretty much looking at quality improvement. Okay. The reason is that quality assurance only takes you to a certain level and quality improvement goes on. And that's important to remember. So if you come out of this unit with one thing, know that they're different things and tell other people when they get it wrong, because lots of people do. Because quality assurance is about standing still, and quality improvement is about going on, constantly improving, constantly changing. I've done a little table here, which I hope makes it clear for you, and it's something you can think about. Quality assurance is about guaranteeing quality. So it's about usually meeting a set of standards. But quality improvement is about raising quality, because it's about, yeah, sure, we meet the standards, but then we will do process to see how can we do it better, how can we go above the standard, how can we set a new standard. Okay. Quality assurance relies on sort of fairly simple inspection, a process. As I said, that CQC come in, and their job is about quality assurance, really. They just need to know you're meeting the standards. They are not allowed to criticize you if you don't keep improving, as long as you meet the standard. Quality improvement emphasizes prevention. So really, the inspection just makes sure that you meet it, but quality improvement is about not even getting near contravening the standard. That makes sense. It's about what can you do to avoid any problems. So it's about thinking ahead. So it's a proactive approach rather than a reactive. Quality assurance, you do an evaluation, and if you haven't met something, then you have to take some remedial action to make sure you do meet it. So you react to the areas where you haven't done very well, but the areas where you have done very well, you sort of leave alone. Whereas quality improvement is always proactive. It's like, what can we do still to make it even better? A shorter time, a quicker journey, a more personal one, a higher level of satisfaction. Quality assurance looks at compliance with standards, and quality improvement improves the processes. So when we're meeting this, even though we meet the standards, we can still improve the way we get there. We can find different ways. We could go beyond the standard, or we can just get those numbers up. So say the standard is 80% of the service users have good satisfaction. We don't just want to meet 80%. Quality improvement, you want to, you're striving for that 100%, really. Quality assurance is a specific fix. So, where we've fallen below the standard, as I said, we fix it. Quality improvement is constantly making continuous efforts on all aspects to keep going. It can be quite exhausting, quality improvement. You sometimes you feel like, gosh, I can never stop. So I've met the standards, so can I have a breather? Well, no, not really, not with quality improvement. Quality assurance might rely on certain individuals to go and change something that they didn't do very well, whereas quality improvement is about the whole team together, still striving. Can we make this better? Can we make it better? Can we make the service users happier? Quality assurance looks at criteria, what are the requirements. Quality improvement is much more process based, because it's like, can we all, there's always some tweaks we can make to a process or the way we do something to make it better. Quality assurance asks, do we provide good services? Yes, no. And quality improvement, you can see it's much more wide ranging. How can we make our services better? So it doesn't matter whether our services are good or bad, we just keep wanting to make them better. So if you think about that, quality improvement is much more aspirational, and it's what we should be aspiring to. Okay, so that's a little bit about what is QA, QI, and the role. So the sort of things you need to be doing to achieve improvement or to meet the standards for QI. So I think most of you have probably got a good idea of that, because we've talked about things before. I'm going to give you two models for ensuring quality improvement. Now, for your assignment, you can use my two models or you can use other models. I am just giving you the two most commonly used ones that are used in healthcare. Okay, so you won't go wrong if you use those two models. If you want to do a bit of research and bring in another one, that's fine, but you need to be very clear. You need to have some good evidence that it's used for healthcare. Like I said, I don't want you to bring me something from BMW's car plant. I want, if you use any examples, I want them to be clear health related. Now, I don't mind if it's hospital, clinic, care home, um, anything like that, but they do need to be healthcare. So, as I said, these two models are used every day, definitely in the UK NHS, and they're certainly used in the States quite a lot as well. So, you'll be fine. They may well be used in your home countries too. If your home country is using something different, please use it, as I said, as long as they're health examples. Okay, so I gave you a little bit of the thought about some of the origins of quality improvement. And this really goes back to the early 20s, but really built in the 1940s and 50s. And it really comes around the time of production management. So the time when factories really got going, because that's where it was all developed, really, and production lines. And that's why an awful lot of work in quality improvement was actually in the car manufacturing factories of the 40s and 50s. Now, quality improvement techniques were actually developed in Japan, and the most famous exponent of it was Toyota. And so, whenever you look at QI, you will see the Toyota factories used as the sort of shining example because they really developed the first quality improvement techniques. Before that, factories just happened, and they just plodded on, really. But it was the Japanese who kept saying, "Oh, we can make this better. We can make it work better." So you'll find a lot of stuff defers to Toyota particularly. In America, F. Edwards Deeming is the name that comes up. Duran also, Duran, that is not Duran, it's Joseph Duran. Often comes up. Deeming particularly, he wrote many books, and you'll see them. They will certainly come up when you do some Google searches on quality improvement. And his stuff was sort of translated into the big manufacturing plants in America as well. So the Ford motor companies and other sort of manufacturing like canneries and things like that in the States. I've also mentioned Don Berwick, who was quite well known in the United States, again, because he focused on QI in healthcare particularly. So he might be somewhere you might want to do a little bit of research into him, get some ideas as well. And coming out of these guys' work, particularly Deemin and Ishikawa, several quality improvements approaches and methods draw from these. And the two I'm going to talk about draw from these. I think Deemin's responsible for the first one, and the lean method is definitely Ishikawa. So we're going to have a look at something is known PDSA, Plan, Do, Study, Act. And it's one of those great circles, and it reflects the circles that you've looked at in your level 3 and 4, really. It will be fairly familiar to you. The language might be slightly different, but it's, when we looked at health promotion, we had a circle how we put things into place, and they pretty much did Plan, Do, Study, Act as well. So let's have a look. Started out as the Plan, Do, Check Act, and then it changed to Plan, Do, Study Act. And again, it's based on a lot of Deemin's approach to organisational development. It provides a framework for developing, testing, and implementing change. So it's a change management tool. So if you look up change management, you'll often come up with PDSA as well. It's got a sort of scientific approach to it. That's the study part where you gather data. And it lets you test out changes on a small scale and then you can implement them on a big scale. So this is where you have sort of small pilot schemes. So if you want to make a whole hospital change, you might pilot it maybe in one ward and see if it works. And then if it does work, then you can roll out your stuff to like a couple more wards. And if that's working well, then you can take it to the whole hospital. So it's fairly structured and, done in the sort of slightly scientific way, step by step. But the most important thing is you need to know when you want to use it and what you want to use it for. And it's really, you have to know before you start what you want to achieve, what change you want to make. And you have to think how you're going to measure that. Okay, so let's have a look. So there are three, with PDSA, there are three essential questions really. The first one is, what are we trying to accomplish? So to do this, your team needs to set a very clear and focused goal. The targets need to be measurable when you think about them. That's your SMART measurement, remember, SMART. And there needs to be an element of leadership. So like the management needs to take it on board as well and support the team in doing it. It's not something you should do on your own. You should do it with your team manager, and the manager should, be able to make, you might need some finances. You might need to move the rotors around to do it. So the manager needs to be sort of very involved and behind it. And they should be relevant, and they should have a bit of boldness about it. So you're not just teeny tiny changes, but remember, you're looking for service user satisfaction. So that would be the sort of open of the question really, because it's going to try to achieve something that maybe service users aren't satisfied with at the moment. That will be your impetus really. Or if people are satisfied with lots of your work, remember, and I said, and you're meeting your 80% satisfaction standard, then you're really looking for your 100% satisfaction standard, aren't you? So I've given you a little question that was used in a cancer service. Okay, just to give you an idea of a sort of question that they set. And their aim for this improvement was to improve access, cancer services, speed of diagnosis, speed of starting treatment, and then improve the patient care for people who are suspected of having bowel cancer. And then they went on to say this will be achieved by, and they put their measures in. Okay, so that's just to give you an idea of something you could maybe look at. For say your care home, you might want to improve access to the care home. So if someone actually applies to move into a care home, does it take weeks? Does it take days? Does it take hours? How quick can you get everything organized? So you might want to improve those timescales. So the question one, what are we trying to accomplish? We need to be clear, and we need to come out with a goal, as I said, that's measurable. There's no point coming out with something that's so high flying and floaty that you could never measure it. Remember that? And remember, the SMART. Remember us. So in other words, our questions need to be SMART. Specific, measurable, achievable, realistic, time bound. Okay. So the second essential question is, how do we know if the change is in improvement? And again, because it has to be measurable, you should be able to show if there's been a change. So for the cancer question, you would have to measure any outcomes, wouldn't you? Like, has the waiting time reduced? Are people starting treatment quicker or slower or the same? So has it not changed at all? So it's the data gathering, really. And if we make a change, this should affect the measures. So your measures should take you, from 80% satisfaction to 90% satisfaction or something like that. And also you need to show it over time, because we can't just have a snapshot of on Tuesday afternoon somebody started treatment within 3 days, but for the rest of the time it takes 3 weeks. Okay, you need to show a little bit more sustainable achievement than that. Okay, before you change the whole service to a new process. So the measurements are really important. They're not for judgment, they're not for criticism, they're not for you to go and have a go at the team. They're for you to say, okay, we've got to learn from this. We're still weak in this area. We can't diagnose quick enough. Why? Because we have to queue up for a machine. Why? Because it takes another team 3 weeks to give us the diagnosis, maybe, and then think about what can we do about that. The third question is, what changes can we make that will result in improvement? So here you might need to do some research, get some ideas from other teams who are very successful. If you know another team have sped up, again, staying with the cancer service question here, that that hospital over there managed to start their treatment within a week and we take 3 weeks, maybe we might go and spend some time with them to find out, what process are they doing that's different? How did they make that change? There's lots of research out there that you can read up. So a university hospital might have written up on something where they've shown where a change in process has improved. You bring that in, really. So what changes can we make? Okay, so those are your 3 questions. What are we trying to accomplish? How do we know if the change is an improvement? And what changes can we make? There are your 3 questions there, and then below that you see the Plan, Do, Study, Act circle. Let's have a look at that now. PDSA cycle. So the first quarter starts with plan. What will happen if we try to do something different? So in that quarter, we have our question or our achievement that we're aiming for. We maybe have some predictions from the team saying, I reckon we could, if we did this, we could improve it by that much. And during that quarter, you actually put your plan together. Okay, what are we going to do? In the second quarter, it's as you can see, I've got let's try it. The second quarter is all about the doing. So it's about implementing the plan, carrying it out for a while, documenting any problems, documenting any successes. So start to sort of gather your data, start to measure it. In the third quarter, before you leap forward, you do it for a period of time, and you've got to assess that the period of time is enough for you to gather the information that you need, see whether it's worth rolling it out. So if you're doing, one hospital ward, one cancer service, will you roll it out to others? Or will there be work need to be done? So the study time, this is when you get all your data together, you analyze your data, you have a look at what your objective was, you identify whether it's achieved, has it fully achieved it, has it partially achieved it, has it not achieved it at all? And then you would write a report and summarize all your information together. circulate it wherever you need to, and then maybe come to some decisions on it. So during the study time, that's where you might have the team meetings or meetings with senior management about, actually we think we've evidenced it. We think we should take this forward and roll it out wider, or make this a permanent change and keep doing it this way. So that all happens in that third quarter. The fourth quarter is when you implement it. You say, right, yes, we've identified there's enough information for improvement. Senior management has said, good, well done, go forward. So you actually change your processes formally, make sure that everybody involved with the service knows the new process and goes forward on it. If you think there were weaknesses in it, if you think, well, it's made a bit of a change, but not really enough, then you might want to tweak it a bit and have another go at going round your circle again. Okay, so instead of incorporating that as a solid process, say, actually hasn't done it that much. Have a think, can we do something better? And you go around again. When you get back to the act quarter and you think you've really got something that has shown very clear improvement in, substantial improvement in a number of cases, then you might want to roll it out further. And as I said, take it as a permanent process change. So that's PDSA. It's fairly simple. It's the same as most planning processes you'll probably recognize. The language is always slightly different, but really the process is the same. And this one is commonly used in a lot of NHS services, especially small services, where it could be a change of process or a change of product that they use. It would cover for everything really. Okay, it just could be a personal one for a small team or a big team. Yeah, I mean it works for everything really. Okay. The second one I want to talk about is lean. You may well have heard about this. Again, you hear about this a lot in business. This is developed from the Toyota production system. Ishikawa created the lean system, and it's applied in many competitive sectors. Tesco's, the big supermarket, I don't know if they have them in your country, but they're massive here, and we've got a few in Europe as well. Is one of the biggest, most successful lean companies in the world. Now, some people say that Tesco is actually probably a bit of a nasty company as well, and I personally don't like them very much, although I do shop there sometimes, because they're very hard on their workers, and well, some of their business practices people are a bit uncomfortable with. They're very cheap, so they don't pay their suppliers a lot as well. So you need to think about whether you think, that's a good idea or not. Some people say they don't have great morals, but they do have a good business attitude. So, work out whether you think morals and business always work together. But unfortunately or fortunately, depending on how you think, this attitude is increasingly being applied in the health services, definitely in the NHS, definitely in some of the American health services. And again, you might want to look into whether it's being applied in the health service in your country. And the idea is to improve quality, improve safety, eliminate delays, reduce length of stay, but use no more resources. So it's the whole idea of lean is to keep the resource management low, really. So you do more with the same. So in other words, not chucking a load of money at a process to make it better. That wouldn't be a lean process. The idea of lean is to get rid of waste wherever you can. Wasted time, wasted product, wasted staff. Okay, so have a think about that. You can already maybe think of some critical approaches to that. There are 5 principles of lean that you would use in any way, be it manufacturing a car or running a hospital. It's a circle again, as things ever are. They just keep revolving round. Starts off with a value stream. You identify the vital steps that facilitate an effective production on the service line flow. And you also look at unnecessary steps that reduce in waste. You optimize the workflow by eliminating the non-value steps. And that creates a value, what is known as a value stream. So you've refined it and taken out any extra unnecessary things. And this could be something like a new person coming to the service and having to tell their story or give their background 3 times. It's unnecessary to the service user. In fact, they normally get irritated by it. And it's time being wasted, staff time being wasted. It could be used on other things. So that's a value stream where the person only has to say it once and then everyone can access it. So that could be about having good electronic notes that people before they if the doctor comes along and before they meet the service user, they can actually see what you wrote in on admission, so they don't have to ask them the same questions twice. Okay, that's quite a classic value stream. Flow is the next step. Eliminate steps in the workflow that potentially cause interruption, delay, or destruction, and create efficient steps without the negative effects, again, to form a value flow. So there might be something that says causes interruption and causes delays that could be removed. It could be having to get approval from a certain thing when the person's not on shift, or is there a way, can that be delegated so you don't have to wait? So you want to move someone into the care home, the manager's on holiday for a week, is that process delegated so you can actually approve it on the day, something like that otherwise the person delays coming in for another week. So you want to form a value flow. The next one is something known as pull, which is known as supply only on demand. And you might have heard this when you hear a lot of stuff about business. They call it sort of on time. So in other words, they don't do things before they need to and have it sitting around, because that's wasted process and wasted money, because the idea is that just because they've built up a load of these, you might suddenly not want them anymore, and you've got a whole shed load of stuff waiting. Now, how does that work in care? Well, it might be stocking up on stuff to a point where you just have too much in the cupboard. And this is certainly something I remember from my time in the NHS. Stock enough stuff and then finding out that legislation has changed and you can't use that product anymore, but you've still got thousands of pounds worth of it in the cupboard. So supply only demand, produce only when the customer pulls, and pulls is when the customer requires, so that no resources are wasted. Which means that actually a lot of cars nowadays are built to order to a certain point. So you go into, say you want a new BMW, for instance, or a new Toyota, let's use the man who invented it. You go into the showroom, they have a showroom model. You go, yeah, I want that, but I want it in blue and I want this, that, and the other. And they say, okay, madam, that'll be 5 weeks delivery. And you say, fine, and you go away, and then you come back and pick up your car. Now, it means they haven't got a shed load of blue Toyota Yaris's around with pink leather seats, that just in case you might come along and say, I want a blue one with pink leather seats. They will do that to order. And it means that there's no money wasted, cars sitting around, nobody else wants a blue one with a pink leather seat. Okay, so you can see the logic in that, in car manufacturing, maybe, and maybe other things. I want brown boots and a size 13 or something, but with red cells or something. Have a think when you're doing your critical analysis. How does that work for healthcare? Just think on that, okay? Do you wait until the service user comes along and says, oh gosh, I need this, and then do you go and get it? Or, you know, would you do it for medication? Would you have supplies, or would you just get the individual member's medication? And therefore, is there a wait for it? Just think on some of those things, okay? The next step after pull is perfection. You strive for perfection by continually removing successive layers of waste as you spot them. So keep reviewing it, keep looking to see if there's any place we can shave it off. And remember, the focus is on waste with lean, it's on waste. And it could be time, it could be stuff, it could be people. Okay? Anything. And then you go around again to value, identify and create products or services that have add value to a client's objective. So hopefully the moving around the circle means that you've added value to your product, and it's meeting the client's objectives, and it will ensure full customer satisfaction. Now, the idea of lean usually means that you've got no wasted time sitting around. However, the pull bit sort of makes it a bit awkward, because it means that if you want something special, you have to order it. So you will, you know, whereas most people would like to go into a showroom like, I want that car and I want to buy it now and take it away. So there is a little bit of incongruence there, really, between what's good for the organisation and what's good for the customer. So you might want to have think about that, you know, is there an area that you can criticize there? We've looked at 8 types of waste in hospitals. Someone actually did some research on it, so you can take the lean idea over into hospitals itself, and they came with very clear 8 types of waste. You might think about, can you reflect on this, any use for your care homes? Defects, overproduction, transportation, waiting, inventory, motion, overprocessing, and human potential. That's a good one. We'll think about that a bit. Defects, bits missing, or somebody doing something wrong, following the wrong process, having to inspect for errors or fix errors. Okay. So this is like maybe someone giving the wrong medicine, or the medicine, you know, when you take your medicines trolley around, that person's medicine's not in the trolley, time wasted there. Or someone's given them the wrong dose and you have to go around and deal with it and write all the reports and stuff like that. Okay. Overproduction, doing more than what is needed by the customer or doing it sooner than needed. And here the example they've used of hospitals is doing unnecessary diagnostic procedures. Now, as a patient, you might think, well, I want all the diagnostic procedures I can get, quite honestly. If I've got a pain in my tummy and I don't know what's wrong with me, I want, you know, I want everything really. But the view is that they don't throw everything in the kitchen sink at you. They do one thing, and if it's not showing up on your, you know, X-ray or ultrasound, they might do a CAT scan. So they'll save the expensive MRI until nothing's showing up on the other diagnosis. Now we know that, and we know it's because the MRI is very, very expensive. And there's also time involved going back for appointments as well. So they wouldn't make you go to all 3 appointments unless there was nothing found at the earlier one. So it's sort of saving the time of the service user. But actually, I think there can be a delay, especially people looking for a cancer diagnosis. You know, they might actually say, well, we won't do the short ones, we'll go straight to the MRI, but they don't tend to do that because MRI is very expensive. So they'll tend to do the cheaper ones first. You can see the logic to that. But I think sometimes delays could occur because of that. Transportation, unnecessary moving service users around. And think again when you're in a hospital, you have to go up here for your x-ray, down there to get your medicines. Service users are marching all over the hospital. The other problem is that, you know, specimens or the labs are a long way away. So if you're in emergency and they have to go to the main lab to get bloods done, and someone's in A&E, um, checking on a cardiac arrest by using bloods and things like that, they've got to wait for a porter to bring them back. Maybe it'd be better if they had a very small lab in A&E, so that was manned 24 hours, so that all tests could be done literally as people were standing there. That's an example. Waiting for the next event to go. It could be patients just waiting for an appointment, or employee waiting because there's a problem. So, you know, you take somebody down as a nurse, you push somebody downstairs for an x-ray, and there's a backlog at x-ray, and you're stuck there with the patient, and it could be for an hour, you know, so the work you're normally doing on the ward isn't getting done because you're stuck there down there escorting, you know. So is there a way that that can be improved? Inventory, too much stuff, spoilage and wastage. Lots of supplies, people buying too many supplies, and they may have a use by date on them. And if people buy too much stocking, they might have to throw stuff away because it goes out of date. Motion, lab employee, well, that's the lab one again. Walking miles per day due to poor layout, really. Very difficult in a hospital because you've got to put stuff somewhere and it can't all be on your doorstep. I can't imagine how you could build that, really. So sometimes you'd have to walk for something, but maybe being creative, like I said, a very small lab, maybe in A&E, so some things could be dealt with. And then the labs being nearer to the wards, and they're not. They're often in the basement, hidden away in some corner somewhere. So, you know, X-ray being closer to A&E. They often are actually, but there's still time. Over processing, doing work that's not valued by the customer, the service user. Um, and a very simple example here is put a date stamp on forms, but the data's never used. So no one ever looks to find out, you know, if that was done within a short time or a slow time. So it's again not using your data, gathering data but not using it is probably something, or reproducing information but nobody doing anything with it. Human potential, which I think is very interesting. Um, Very often you see this list of 7 types of waste and they leave off the human potential. I sort of decided I'd show you this one because I think it's really relevant. Waste and loss due to not engaging employees, listening to their ideas, or supporting their careers. People leave the job because they get fed up. And very often it's because they're not listened to, or they're not being part of any decision making process, or people are not helping, you know, senior managers are not helping junior staff to develop. And it might be getting some practice at supervisory work, it might be doing something specialized that they're quite interested in and going off and doing a course, or getting to do that on the ward or in the care home. Something, you know, somebody might be really interested in day activities, maybe getting them to be part of the day activity team, and that might be something they might want to move into in time. But, you know, giving the people chance to develop themselves. Employees get burnt out and they quit giving suggestions for improvement. So the team doesn't improve because people don't care anymore and they don't get involved because no one asks them and no one listens. But eventually you will lose staff, which is a waste of human potential, really. And I think that one's important. But like I said, very often these 8 types of waste for the end, they often leave that one off, which I think is a bit sad. So the lean process, here's a picture of somebody doing a lean process, and I've done this with a few different teams over the years in different jobs, and that is actually quite interesting. So as you can see, the idea is that you get all the different parts of a process. It might be admitting a patient to a unit, or preparing for a clinic or something like that. And what you do is you get all aspects of what has to be done to make it work. You pretty much write them down, or all aspects of what is done at the moment. You write down each aspect. And as you can see, use a notice board or a whiteboard, and you do it on post-it notes, and then you stick them up and put the process together. And then say underneath, well, what one could be taken out that would speed up the process, improve the process. Okay. So once you've worked that out, then you put together an action plan with clear timescales for how you're going to introduce the new process. And very often you can get immediate benefits of just time, really, without any major resources. And as I said, the old idea of lean is not to throw a lot of resources at this, although you might have to, I don't know, buy a new machine or something. So it might be a one-off cost, but then the processes can improve. But like I said, if you build a little lab area, small lab area in your A&E department where bloods can be tested, it doesn't, it might only take converting a room and getting a few bits in. Although it would be quite expensive outlay, there would be more money saved in the long run. So you could do an invest save. But lean is about not throwing loads of money at something in general. Okay. You could do it for a one-off, knowing that it would save money in the long run, but it's not about costing more every year. So this, as you can see, this idea with the post-it note is pretty much the way it's taught to be done. It's the way I've always done it. And you just write all the process up, and you go, what happens if we take that? See the one that she's pointing at. Well, do we really need to do this one? Can we take this one? So the ones they've got down there are probably ones they've taken out, maybe. And then you end up with a nice refined process. And it's sort of that simple, really. Okay. It's a great brainstorming thing to do with a team, and the team can get really involved in it. So it's something you could consider doing when you were doing a bit of team building or something like that, or an annual team get together. So it's a really good idea. So what are the advantages of using lean processes? You focused on waste reduction, which generally cuts costs. Lean thinking and its associated tools help you, the organization, to identify how the work gets done in the first place. And sometimes when you look at it, you think, oh, blimey, why do we do that? And how to eliminate waste and confusion in processes. Because some people will say, I've never known why we've done that bit. I don't really understand it. And, that bit might be important. And maybe another team member can explain, and that person could feel a bit more on board with doing that section. So even if it's something you're not choosing to cut out, it can be quite valuable. Focusing on eliminating waste will help cut costs, adds value to your processes, and it also eliminates ineffective effort. So it takes away things that you're doing for no reason. And then I think most of us in our jobs have walked about going, why do we do this? There's no real reason for it. It's already been done elsewhere. Why are we doing this? And this is doing a lean process helps you say to your manager, look, we really don't need to be doing that. So it can be really useful. And it does require a bit of a shift in thinking about how we manage and run NHS organisations, okay? Because that's not often, the NHS was never developed to think about how to reduce waste. Any disadvantages? This is something I'd like you to reflect on a bit. You can do a bit of research, do some wider reading, and maybe have a chat with uh, colleagues that you're working with, and see what they think. Think about, well, if we did that on that process, what do you think would happen? Or maybe they can highlight immediately there are some areas where we could just cut something out anyway, and I totally agree, and I wish we did it. Or they might say, well, I don't know about that, because if you took that away, then there'll be a problem. One of the issues I can give you as a reflection that's being picked up in our COVID review. It's taken us a long time in this country to do a COVID review, but we are finally doing it. It's probably going to take years to do, because these things do. Um, what had happened was, because of lean processes in the NHS, a lot of old PPE had been got rid of, and they weren't keeping high levels of stocks anymore. Right, instead of buying box loads of gloves, box loads of gowns, box loads of masks, they were just buying smaller amounts, and encouraging people not to waste them, and take one, throw it away, take one, throw it away. So there were some issues there. There's issues across infection, because people weren't getting rid of their gowns as often, and then they had to sort of quickly stop. They were using cheaper versions of stuff which weren't as good, and because they ran stocks down, we're only having small cupboards with small PPE stocks instead of, I mean, in my day when I trained as a nurse, you would open cupboards all over the hospital, and like linen and gowns and boxes that would just fall over. Everybody had stocks to last for about half a year. It's just the way it was. But it meant we never ran out. We did run out during COVID. And then when we went to get PPE, we were fighting all over Europe to get the same PPE from the same companies. What happened was some fairly dodgy, is probably the best way to put it. Companies started up overnight creating PPE, and a lot of it was bought, but a lot of it didn't meet the standards and the quality, and put the nurses and doctors at risk. But we had to use it because we didn't have PPE, because we didn't have a stockpile like we used to. Some might say that PPE can't really go off. Why was it not kept? Some stuff that had a date on it to say that it was sterile, and that might well have been out of date, but quite honestly, it probably would have been safer than not being able to get your hands on it at all. So there can be an issue with the sort of pull aspect. If you don't have stuff, you can't do that. You've got to have some stocks. And in fact, as I said, we suffered from not having enough stocks. And then when we went to buy it, we couldn't get it. And then when we did get it, it cost 3 times, 4 times the price, because it was being produced during COVID. So have a little think about that. So when you do it, you need to discuss both approaches, strengths and weaknesses, and see what you think as your critical appraisal of it. I've asked you to read up on Six Sigma. Six Sigma is the other thing that's used a lot in the NHS. It's a sort of building on from Lean and the other one. It's just a much more formal process, but the NHS seems to love it. I've worked with it. I think it's overkill, but you read up on it, and if you want to use Six Sigma instead of one of these two, please do. Okay. And like I said, you can find others, but you need to give me a bit of an example to show me they have actually been used in the NHS. In health, it could be health in your country, health in another country. This one, you don't have to keep it down to the UK. It's just any healthcare. Okay. Okay, well, thank you for that. This is week 1 over with. Just remember, any questions, WhatsApp me, and I'll see you in week 2. Thank you. Bye.